thank you all for coming. Been extremely generous to take an afternoon out of your time, out of your day, to come and talk to us about learning healthcare systems. I'd like to thank particularly Dr. Richardson, Chair of the College's Clinical Informatics Committee, who has provided us with the beautiful venue. And as well as that title, he's also a previous clinical supervisor of mine. And also Ryan McGowan, who's just left, who was also very helpful here at the college in setting the whole thing up. We'd also like to thank the Health Foundation, who have funded the research, and they've been very generous. And I think we'll be joined later by Adam Steventon, their head of clinical informatics. And then also the NIHR, who are paying my salary, so they're quite helpful as well. And from Newcastle, there's myself, there's Greg Maniatopoulos from the Institute of Health and Society, and also Fergus Fairmichael, who's also working on the project. And thanks to Chris Matheson, who's our cameraman today, and Chris Shipton and his team of graphic recorders, who'll be making it all look, making the outcomes look beautiful. So it might be helpful if we just go around the table quickly so that everyone knows who everyone is. So I'm Tom Foley. I'm from Newcastle University, and
John Fox from Engineering Science, Oxford University.
I'm Nina Pimwell. I work at NICE and I'm currently seconded onto the Innovative Medicines and MedTech Review, or the Freeman Review.
Hi, my name is Sheriff Orkan. I'm just about to finish my PhD at UCL, and I've been working as a software developer for 18 years now.
David Ingram, Health Informatics at UCL, now retired.
Hi, I'm Greg Maniatopoulos from Newcastle University, Institute of Health and Society, and interested in the role of technological innovation in healthcare.
I'm Derek Tracy. I'm a consultant psychiatrist in South East London, where I'm the clinical director for inpatient and crisis services, and I'm tasked with trying to digitise and embed clinical outcome measures into our electronic records.
I'm Graham Willis. I'm head of research and development at the Centre for Workforce Intelligence.
I'm a workforce analyst at the Centre for Workforce Intelligence.
I'm Amanda Hunt from Health Research Authority. I'm the Engagement and Policy Manager.
I'm Anna Lee from Health Education England, and specifically Project Manager for the Commission on Education and Training for Patient Safety.
Hi, I'm John Richardson. I chair the Royal College's Psychiatrists Informatics Committee, but I'm also Group Medical Director in Northumberland Tyne and Weir Mental Health Trust at Newcastle as well.
Hi, I'm Michael. I'm consultant haematologist now at UCLH in London. I graduated from Newcastle, so there's a link there. I was a previous chair of the advisory panel for the CCR Leaders Network, and currently in UCLH we're trying to understand how we can measure outcomes in our cancer patients.
Brendan Delaney, chair in primary care research at King's College London, long-standing interest in clinical research, informatics and medical decision making and diagnosis. I'm also a one-day-a-week GP.
Hi, I'm Fergus Fairmichael. I'm a doctor in the Newcastle Tyne Hospitals and the research associate for this project.
Great. So in a few minutes I'll give a very, very brief overview of the field of learning health systems as we understand it, and later on you'll get a much more informed talks from Professor Fox and Professor Delaney at the second plenary session. But first of all, Fergus is just going to talk a little bit about how the day will run and the project methodology.
Okay, so we should all have an agenda in front of you. The important things to note is coffee is at 2:20, and beyond that there's 2 breakout sessions with 3 focus groups from each of those. We've tried to assign people to their area of expertise as we could, whilst trying to maintain numbers in the groups as well, so apologies if it doesn't quite match up as you anticipated. And we'll aim to finish up at about 4:30 if we can do. You should also have a consent form in front of you, and that's part of our university ethics approval requirements. In case you haven't realised, we do have several cameras around the place. We will be recording to try and get some material put up onto the project website if possible. And then we'll have the graphic recorders obviously recording things as well. We'll try and use some of that material too. Beyond that, so to give you a little bit of information about the methodology for our project into learning health systems, the main aims were really to explore the challenges to the development of learning health systems, the implications on the various different fields that could be affected by them, and also to try and raise awareness amongst clinicians and policymakers and so forth, and researchers and everything that's into the field, which isn't quite as well known in the UK as it is elsewhere, such as in the States, really. So the methodology side of things, it all began a few months ago. It's a 6-month project, and we started off with a literature search trying to look at the various key papers and so forth around the area, and from that we've sort of developed some of the questions and implications that we're going to be looking at in today's seminar. That led to a sort of snowball approach to identifying key people in the field and organisations that are affected by, or could potentially be affected by learning healthcare systems. And in total we've engaged with probably around 60 people in the fields affected. Following on from that, we've obviously had interviews with some of them, and we're running sessions like this at the seminar. And from all of this and our literature search, we're planning to add evidence as we accumulate it to our project website, which we launched yesterday, and try and encourage people to engage with the whole project as a whole, and that'll help to evolve the project further as well, hopefully, if we get a good level of engagement. So ultimately we'll be looking to produce a thematic analysis of everything that we've accumulated, and with what's been added from users onto our website as well will be incorporated into that, and we'll try and disseminate that through public media and possibly publication, hopefully, with the Health Foundation as well at the end of it, and we'll see what we can get out of it. So before I hand back to Tom again, I'd just like to thank everyone for taking the time out of their busy schedules to join us today, and we look forward to seeing what we get out of the session.
Great, thank you. And we are expecting a few more people, but I think it's best just to get started, and they can catch up as they arrive. I suppose I was talking to Prof. Delaney just before we started, and as he said, the term learning health system can mean different things to different people, and to even more people it probably means nothing at the minute. So it would be useful to know just how many people had even heard the term or had an idea of what it meant before they got an email from us. So just with a show of hands, has any did people know about it, hear about it? Yeah, well, obviously. Yeah. So I mean, I think that's interesting, because a lot of the people around the table were actually doing things that would be considered as part of a learning health system, despite the fact that the term isn't particularly well known here. So we'll have a look at the definition and what it means, and some examples. And as for myself and Fergus, we're both clinicians working in Newcastle, and we came to it really from a kind of frustration with the lack of evidence in clinical practice, and something that Dr. Richardson will know. We've had discussions about this in supervision. We're often treating patients, and often we're not entirely sure whether the particular medication will work for them, because there may have even been an RCT, but the RCT, isn't on patients who are like our patients, with particular characteristics and comorbidities and so on. And there may be lots of RCTs that we have never even heard of, because so many have been published that we can't keep up to date with it. So that was kind of where we came to it. We're not, experts on the IT side, or necessarily experts on the quality improvement side, but we've kind of talked to lots of people, and that's kind of what we're trying to do, is to bring it all together. The Health Foundation, I think, are quite interested in learning health systems because they have recognised the importance of data analytics. They've just recruited an in-house data analytics team, and they've started funding health informatics projects. And I think they're keen to see, where their resources can do some good to move the field forward. And we'll talk about the different scales at which the learning health systems can work at and some of the big issues, and then we'll go into those big issues in the focus groups. So the context, really, everybody's aware of this. There's not enough money in the health system. Inflation has been outstripping, health inflation has been outstripping inflation in the general economy for pretty much the entire lifetime of the NHS, and it's becoming increasingly unsustainable as the proportion of GDP dedicated to health increases. And at the same time as that, we've got an ageing population, an increase in chronic illness, and various other factors that are coming together to increase the cost pressures in the health service. So there's a feeling that something has to be done. At the same time, in the rest of our lives, we see IT disrupting industry after industry. We're just thinking today, we came here in an Uber taxi, and we stayed in an Airbnb last night, and there's two industries that have been radically disrupted recently. And we have Moore's Law, which has been delivering exponential growth in processing power at the same time as exponential decreases in the costs of those things. And then we've also got an increase in focus on measuring clinical outcomes. So we want to know whether the treatments that we're giving people are actually working or not. And there's more and more data coming from those sort of projects, more outcome data becoming available all the time. And then, as we said, there's a proliferation of evidence. So there's 500,000 new articles every year in healthcare. And there's no time to read them all. But at the same time, there's a lack of evidence concerning the heterogeneity of different patients. So those two things help to form the context in which the learning health system has been conceived. And it really was popularised by the Institute of Medicine in 2007 with their first report of that name. And it can mean different things to different people, and I suppose what we're talking about here really is, the use of routinely collected data, clinical informatics, in order to feed back into the system in a way which brings about change and brings about improvement in care for patients. And that's probably the best way that we can conceive of it for these purposes. But even that gives a very broad range of different things that it could cover. So one of the key people working in the area of learning health systems is Professor Friedman at the University of Michigan. And he conceives of the learning health system as a cycle with two halves. And he would start at the bottom there where we would ask a question of the system. Then we would assemble the data, we would analyse the data through various methodologies, and we would interpret it, we would come to some insights around what the data is telling us. And then the second half of the cycle, which is perhaps even more difficult, is feeding it back into the system and bringing about some meaningful change in practice and eventually an improvement in care, improvement in outcomes. So Prof. Friedman talks about this cycle as being the double helix of the learning health system. And he talks about three elements to it: the blue side, the red side, and scale. And what he means by that is that a learning health system can operate at almost any scale, from the personal up to the international level. And we'll go through a couple of those and the examples at different scales. So within an organisation can consider itself to be a learning health system, and it may do some of the things that we've listed here. So we visited Geisinger a couple of weeks ago, and they consider themselves to be a learning health system, and there's, objectively, they are considered to be one of the leaders in this area. And one of the simple things that they do is to use automation to bring the routinely collected data through into the systems that clinicians use in a joined up way, and as they put it to us, to make the right thing to do the easy thing to do. So that's important. And then it can feed into clinical decision support systems, and this is an area that Prof. Fox might touch on later, with his openclinical.net initiative. And that's really about bringing the routine data through in a way that can help clinicians make decisions about the care they provide. Then there's predictive modelling, and that can operate at a couple of levels. So it can operate at the patient level, so we can identify variables that are useful prognostic variables for patients. And there's some work being done by there's a lot of this going on, but outcome-based healthcare is an organisation here in London that are doing a lot of work around that at the moment. Unfortunately, they were going to be here, but they couldn't make it at the last minute. And then at the systems level, again, in Geisinger, we heard about how they were using predictive models to identify patients at a high risk of do not attend, and then putting in strategies in place to get them along an extra effort. And also forecasting models so they could tell how busy different parts of the system were going to be in the next 72 hours so that they could redeploy their workforce and use people more effectively. And then we spoke to Academy Health about how their members, the health services researchers, were actually using a lot of this routine data to really change the paradigm of their research. And it was a similar story in comparative effectiveness research that can be done at the organisational level. And then there's a kind of something that's gained a lot of publicity in recent years has been IBM Watson, which is the supercomputer that can play Jeopardy, where they're now training it to do things in the healthcare field around cognitive computing, so that it can make some sense of the huge volumes of data that are being produced. We visited them and we learned a bit about that, some of the possibilities, but also some of the limitations that may have been ignored in some of the hype that's been produced. So at the national level, a learning health system can mean something different. It can mean a network of networks. We can have, for example, the Food and Drug Administration in the States have a thing called the Mini Sentinel project, where they have about 150 million patients on their distributed network, and they're able to monitor almost in real time the effects of the adverse effects coming from new treatments as they're introduced. And then for comparative effectiveness, we visited Optum Labs, and they were doing some comparative effectiveness work where they're actually using routinely collected data and observational methodologies to replace some of the work that previously they would have used RCTs to do, and they could do it for orders of magnitude less money. In the UK, we've seen Q Research, which is a primary care database that's organised partly by EMIS, and they've used that in the past for tracking flu outbreaks in real time. And again, Academy Health told us about work that they were doing in this area, and the International Consortium for Health Outcome Measurement talked about how they were using benchmarking and hierarchies of outcome measures to provide management information to individual providers so that they could improve by learning from each other. Big issues obviously at the national level are around interoperability, and we'll talk more about that later, and also the sort of live debate as to what approach you should use to build these networks. Should it be a centralised system or should it be distributed, which we'll come back to. At the international level, there's a scope for much larger databases, potentially of hundreds of millions, if not billions, of patients within the databases. The ability to study rarer conditions, immigrant populations, and to make comparisons between healthcare delivery systems at the national level. And Prof. Delaney will talk about his Transform project, because obviously the EU is probably in a good position, given that it's an international group, but it has a lot of agreements already in place to probably progress with international examples. But again, information governance becomes even more important at the international level, and there are also ethical issues around access and justice in terms of which countries are included and which countries are excluded from the system, and what that means for patients there. Technical feasibility is an issue. I suppose we're moving on now to the areas that we're going to cover in the focus groups. we found in the US that they had financial incentives to move towards the introduction of electronic records, and they have made much more progress. So they had maybe 80 to 90% of providers covered with electronic records. But looking at interoperability, that has not had so much progress there, and they've got major problems now with interoperability as we do, and we can explore some of those issues in the focus groups. And again, the centralised versus the distributed, and the different pros and cons of those and the potential for hybrid systems. And then obviously privacy, de-identification and pseudo-anonymisation are big issues we've seen with care.data, for example. And these have the potential to completely stop all these potential innovations in their tracks if we don't get the public support. So research methodology is also a big issue. We don't cover it specifically here in this seminar, but we have covered it with other people, and it's talking about potentially the move towards replacing some of the things that we need RCTs for now with observational studies, which, although they're not randomised and have a risk of bias, they are much less expensive and maybe more generalisable to the patients that we actually see in the clinic, and obviously reduce the risk of harm. But that's a live debate as to how far that can be pushed. The underlying data is important to use the computer science term garbage in, garbage out, and then anybody who's seen what some of us clinicians write in the notes will understand that they're not always complete, they're not always accurate, and sometimes they're not even there at all. So it's a key issue, and we've seen various methods of mitigating this problem on our travels. So we've seen automation, particularly around outcome measures. So we've got automated systems that will, say, phone the patient up and ask them for certain outcome measures, online methods, even wearable technologies that can provide very good proxies for some of the outcome measures. We've got augmentation, where some systems involve a human coder sitting in the provider, augmenting the notes to make sure that they're coded properly. We've got predictive coding, so that when someone's typing it into the electronic record, it can help them code it more accurately and almost force them down that route. And then natural language processing, where we've seen a lot of promise for that. So when we visit Optum Labs, they told us that about 70% of their data actually came from natural language processing of free text entries. So the potential there, if that can be cracked, is obviously huge. Then ethics will be a major issue to focus on. And we spoke to Professor Faden and Professor Cass, who are at Johns Hopkins, and they're leaders in thinking about what sort of an ethical framework we need within a learning health system. And they're of the belief that we need a radical departure from the current ethical framework that has a divide between clinical work and research. And they actually think that in many cases informed consent needs to be either streamlined or even not used at all in certain cases, in order to allow the learning health system to generate the data. In order to make that acceptable, they suggest 3 principles, which are engagement, massive engagement with the public and patients as to what studies are acceptable not to have informed consent and which ones still require it. Then transparency around patients coming into the system need to realise that they are in a learning health system and that their data will be used for those processes. And then accountability, so afterwards they need to be accountable to the patients. They need to talk to patients and tell them, this is what we've done with your data, this is what we've achieved, this is the difference that it has made or hasn't made, and be totally open about those things. And back to Professor Friedman's cycle of the learning health system, and to look at the red side, which is knowledge into practice, which is often ignored in the media when people talk about, what can be done with the new supercomputers and it'll put doctors out of business and all the rest of it. They ignore the red side of the cycle, which is about how this is all fed back and how change is actually made to happen in the hospital or in the clinical setting. Traditionally, knowledge has been created journal articles have been written and published, and it has taken an awful long time for findings to make their way into practice. You've probably all seen the statistic of 17 years from a discovery into actual treatment being delivered to the patient. And I suppose one method for improving that situation has been to use guidelines. So organisations such as NICE have got expert groups together. They've brought them in, and they've taken all the evidence and produced useful guidelines that can help clinicians. But again, they're often not actually implemented in practice for various reasons. And then we see work on clinical decision support systems, so bringing it even closer to the actual patient, even closer to the point of care, to try and help that. But really, to understand that, we need to see it in terms of behaviour change theory and other sociological approaches, which we'll talk about in one of the focus groups today. And just to reinforce that point, last week the Health Foundation published a report called Constructive Comfort Accelerating Change in the NHS, and they've identified 7 key factors for change in the NHS. And certainly data analytics is there, but it is one of the 7, and it's strongly connected to all of the other factors, which are the usual suspects that you're all aware of. So, committed leadership, a culture supportive of change, management practices that ensure implementation, an enabling environment which supports and drives change, the resources to support it, and the capabilities to identify the problems and solve them. So no surprises, but we can sometimes forget them when we get into discussing the particular information technology solutions to the problems that we face. And then training in workforce is also a major issue in all of this. What sort of competencies are going to be required for a clinician who works in a learning health system? How do they compare with what we're now training doctors for? And how should we change training or amend training or education in order to make those things basically equip the doctors or the other clinicians with the skills and competencies that they need. And that may have an effect on productivity, it may have an effect on numbers of different professional groups that are required, it may have an impact on the balance between specialist and generalist, and the skill mix, and again we'll discuss that in the seminar. So looking towards the future, great claims have been made about what learning health systems might deliver. So one very eye-catching discussion is around the idea of a green button. So it's been proposed that we could have a system whereby a patient arrives to see the doctor. The doctor types in, the characteristics of the patient, the demographics, but also the comorbidities and the particular presentation. And then, though there may not be an RCT that is particularly focused on that type of patient, they'll be able to click up the green button, which the system will then go away, create a dynamic cohort of all the patients who've ever been treated with those characteristics for that condition, and then bring that cohort back and look at the outcomes and say, well, this might be the most effective treatment for you. Now, these such systems have been proposed, but there has been a lot of pushback against whether that will even be possible. There are technical constraints and there are research methodology constraints that some people believe will mean that sort of a system is never actually feasible. But these are the sort of claims that have been made way into the future. And there are challenges in even implementing the sort of things that we see that I've discussed earlier in the lecture that are being used in islands at the moment. There are big challenges to spreading those out and to make those ubiquitous. And there again around interoperability, the research methodologies required, the ethical framework behind it all, issues around confidentiality and translation into practice. So I've covered an awful lot in a short period of time and probably haven't actually covered even a fraction of the field, but given that everyone's coming from a different perspective, I thought it would be useful to just lay out a baseline of what we're what we're talking about. You can join the debate. You can check out our website, which we did yesterday. We're going to upload all the evidence as we gather it onto the website, and in the hope that that will raise awareness and that it will generate discussion on there. So we've got 5 or 6 minutes where we could take some points. There may be some points that the experts want to make where I've maybe not got things quite right, or there may be questions, or there may be other clarifications that anyone would like to make. Anyone?
Gosh. Could I just maybe just to add one small elaboration, because we had a conversation a few days ago in which I think we agreed that there was a very important distinction to be drawn, that a lot of the current thinking around, you mentioned Watson and analytics, big data, machine learning, the emphasis is very much on data, clinical data, what's the value we can add through kind of advanced IT and other sort of techniques. But that's to be contrasted with, again, the other term that you used is knowledge, medical knowledge. How do we capture that and use that to take that into practice? So there's sort of two sides of this. There's the raw data and the things you can mine from the raw data, and that will include knowledge, experience, evidence, and how do you then deliver that into care? So we're going to see a lot of cycles, I think, this afternoon. I'm going to be responsible for a few of them, but that two halves of the story, I think, is very important to keep clear in mind, because there's so much emphasis on data at the moment, and it really needs to be. We need to be thinking downstream as well.
Yeah, I mean, I completely agree with what John was saying. Both the big data initiatives and the big data analytics initiatives have got a lot of traction at the moment, actually, that's not a learning health system. You have to close the loop, and you need to have consistent representations of knowledge that can then be integrated into care to close that loop, and there's very little attention with that at the moment.
So I suppose that would focus on the red part of Prof. Friedman's cycle. Sorry,
Tony, you said you have to look downstream of the data. I would just add, I think you have to look upstream of the data. The data is generated subject to the practices we currently have, and that may be all we've got, or it may be a source of terrible bias in our data. But in a sense, sometimes one may need to sort of think upstream before one thinks downstream to are we doing the things that would generate that data if we want to be positive about it, or are we doing things we shouldn't do just in order to generate the data if you want to be negative about it? Swiping your card when you go to the supermarket till isn't really what you want to do, perhaps. It's what they want you to do.
Tom, just an observation. I think while realizing that in the new world where information is digitized, in most of the hospitals and GP surgeries up and down the country, the people that actually provided the infrastructure to do this are the vendors and solution providers. I think one thing that's really obvious around this table is, I know you've tried, but none of them are here. And maybe there's something in that, and I'll be interested to know what your experiences were when you went to the US with regards to that interaction between the people providing the solutions and the many people here who kind of know the theory and practice required of a learning healthcare system, and then the people that have to kind of deliver the tools and the stuff to actually do it. So I'm curious about that.
That's an interesting observation. And what several people told us when we visited the providers who are working on this is that innovation is not taking place at the electronic health record level. The innovation is taking place above that at the analytical level, and it's taking place below that at the hardware level. And people at best are currently taking the information out of the electronic records and using it in the other systems that they're developing around that. But they said, and they didn't say that was entirely unreasonable, because someone made the analogy between a nuclear reactor, and they said you don't get to innovate on a nuclear reactor. You have to take the findings out of it, and you have to use it somewhere else. And they see the electronic record sometimes as being so critical that you can't really take chances with it, you can't try innovations with it, but other people, and we can argue about that, that's just what the feedback was, but some people did say that it was very difficult to use the electronic health records as they were, both here and in the States, to innovate, and the innovation was going on at different levels. I don't know if anyone else would have a comment on that.
I think having used an electronic health record and I think mental health sort of just behind general practice in terms of implementation. So, we have a trust that has 6,000 staff and about 22,000 patients at any one time. We've got an electronic health record regardless of age or diagnosis. Implementing that was a lot of pain, to put it bluntly, at times because of the change involved in that, but also getting the electronic health record changed to do what we wanted to do as clinicians. At times the steps involved in that was very protracted. So there is a move to be looking at open source electronic health records, which might be held and owned by the actual clinical teams. And I use clinical in the broadest sense to include clinicians, informaticians and managers, to have that continuous improvement happening at a real quick turnaround, really. So I do think that there is something, maybe it's not innovating the electronic health record itself, it's just how quickly you can change that to then deliver things that you need as a clinician to record, things that the organisation needs to record, and then things that you can use at a secondary use level as well. But the key bit in this is the electronic health record, because that's where the data is coming from. It's coming from that interaction one-on-one with the patient and the individual. So if we can't get that right, then some of this becomes even more challenging to do.
That's actually quite an important initiative at the moment, isn't it? The open source one. I'm afraid that's big mistake the NHS is making at the moment. You're absolutely right about the electronic healthcare record being the core of any potential innovation. You need to carry that information into what Professor Fox is doing to see if you can transform, just a piece of data into some helpful knowledge, and you need to connect that. And the problem you face is you get a black box, and when you need to change something, I'm not going to name names, but there's a famous example known in the industry that putting a single checkbox on a screen with a very well-known huge vendor takes about $50,000. And because of that, I think NHS is kind of incorrectly looking into open source, but looking into the free, license-free, cost-free aspect of open source, with the, unfortunately, in my opinion, naive assumption that you can get people into a room and they can look at 500,000 lines of source code and make those changes, and that's just not going to work. Open interfaces, on the other end, developing systems that are specified and implemented based on open interfaces would help a lot. Well, you can have it open source or closed source under that setting. That's perfectly fine. But just personally, I think, I don't know if Professor Ingham would consider that a failure, but it's definitely been a challenge trying to explain, especially to NHS and to institutions, that look, you can take standards for electronic healthcare records as the starting point, and there's a lot you can do on top of that. But unfortunately, I have to say, I was in Newcastle in the open source day. There was a lot of momentum and enthusiasm and excitement, but it was all based on the, in my opinion, unbelievable assumption that if you just provide the source code, people will just come for free, look at the source code, and solve all the problems that we have just because they can now look at the source code. That is just not going to work.
I suppose I'm looking at a very pragmatic level. When you look at, say, system usability scales on the current electronic health records, they're okay at best. In terms of clinicians using these systems, they're really still quite clunky. So to get them used, you've got to get them to the point that they're as good as everyone around this table has smartphones pretty much. I know that the Mayo Clinic has had a deal with Apple to look at the interface in terms of apps for their electronic health record, which is based on Cerner. So there is that model. But we've got to get there, because if you don't have usable systems, you're not going to get the data in. It goes back to that garbage in, garbage out. Whether or not open source is, and I think it is being used as the holy grail at the minute, and whether that's right or wrong.
And when it fails, it's going to rule out a very good option, just because, well, we tried open source and it didn't work.
Yeah. So what I don't want to do is to take away from what we'll discuss later in the focus group. So I'll take one more point from Prof. Delaney, and then we'll get into the focus groups.
Brendan, please, don't formality. I was with Chuck in Japan last week, talking about the learning health system in Sendai, and he said a very good thing in his presentation, which was if you want to succeed in ice hockey, you skate to where the puck is going to be. And I think that's where we're going with electronic health record systems. They're not the enemy. They just are in a transition between a black box business model and a service-driven business model, and we want to skate to where the service-driven business model is and have the technology to be able to work with them when they get to that point.